Okay, guys, can you hear me? So let's go ahead and get started so we can stay on time. Just because if you get behind time, the buses start getting backed up and everyone gets unhappy. So, all right, so we're going to launch into the next talk. This is essentially, we're focusing on C1-2 fixation, and so we'll get going. So here are my disclosures. None of these are really relevant. I won't be talking about any specific instrumentation. But I do want to take the time for you guys, because if you look around the room, you look at the guys who have traveled from afar to come teach you guys about cervical spine stuff. This is really kind of the who's who of cervical spine, even kind of the who's who of spine surgery in general. But this is really your opportunity to take the time, take this 48 hours to glean as much information from these guys as much as you can, because it's really an amazing opportunity, I think, that you have at your fingertips here. So really use it to the maximal extent. So unfortunately, though, you guys got the seventh inning slump and getting this guy coming in throwing you a fastball. So hopefully you get something out of it, and we'll kind of launch into it. So before we get into kind of modern day fixation, let's take a step back and kind of think about the history of what we're trying to achieve here. And so you look at kind of chronic Atlanto-Occipital instability, think about rheumatoid arthritis and pannus formation, basilar invagination, kind of cranial junction tumors, things that really kind of plagued early surgeons, and fixing them were not easy back then. And so simple things like the anterior cervical discectomy infusion, you think the Cloward paper, you think about the Smith-Robinson approach, transoral approach, which we talked about, all of those really kind of set the foundation for us to really kind of start thinking about fixation. And so Galley wiring, Brooks wiring, and then all the way up to the transarticular screw. Really kind of that's all the steps that we've had to take just to get to where we are today. So a lot of kind of predecessors that have come before us and really allowed us to kind of get to where we are with modern fixation. So this is a little bit of a historical component, but I think we should at least review it because you should have this in your toolbox. But the difference between Galley and Brooks, really the Brooks wiring is sublaminar at C2. And there's nuances to the way that you kind of loop in the bone graft, you place it in between the vertebrae. But in reality, this is for you orthopods out there, this is just a tension band construct. And it's great from a kind of a sagittal plane, but not so great when you think about rotational forces. And so that fusion rate as we start to look at different kind of instrumentation, really was, the non-union rate was relatively high. And so thinking about rotational instability, and then also if you don't have an intact arch, think about a lot of the trauma situations we have to deal with. This is not really a great option, but something that you should at least think about and have in your toolbox. And that really morphed into the transarticular, and this was like the cutting edge thing, right? So when Mogro came out with this really started to provide some actual stability where we started seeing higher union rates and things like that. And really the way I think about it is this is just kind of a long par screw. So where our start point is really about 3 millimeters medial and cranial to that medial margin of the C2-3 facet joint. But what's the problems, right? So the problems with this is that this is kind of a dangerous screw. So if you talk to maybe some of the senior surgeons about placing these screws, placing this with navigation, I wouldn't really think twice, but doing this under X-ray, and it really kind of is kind of a scary thing to think about, because almost 20% of patients aren't even candidates for this screw placement in itself. So steep requirements. So you want to kind of keep your dissection limited, but you really got to extend it, or even kind of have like a thoracic tube to place your instrumentation to, just to try to get a percutaneous method, because that is very much a steep angle that you have to achieve. And like I said, very much a technically demanding. And this is kind of an early paper by Rick talking about the utilization of transarticular compared to wiring, which again shows how old he really is. But it kind of talks about how the non-union rates, how this really drastically changed how we're able to fixate the C1-2, and how this was, like, again, cutting edge at that time compared to wiring. So where did the more kind of modern fixation techniques come in? Well, this is kind of the origin of the C1 lateral mass. So this is by Goel in the early 1990s, where they talked about C1 lateral masses, C2 pedicles, and then fixating it with a plate. And you can imagine that's kind of an upgrade from the transarticular. The downside of that is you got to sacrifice the C2 nerve root. Any of you guys who've ever dissected in this area, it's rife with the venous plexus that bleeds like crazy. So you can imagine it's not very fun. And then we kind of see the transition from that into the early 2000s with the harm techniques, which really has laid the foundation of what we know about polyaxial screws and rods. And really this is kind of widely adapted. And you can imagine, as we all know, how hard it must have been to try to reduce fractures. This kind of has made it much easier for us to not only reduce instability, but really achieve fairly significant stabilization. So kind of getting into kind of the technical aspects of the C1 lateral mass. So thinking about placement, the palpation, the lateral and medial borders of the lateral mass itself, which I'm sure your attendings probably yell at you time and time again. That 15 degrees of medialization, about 25 degrees cephalad, and I'll kind of talk about maybe some of the nuances of that. But this notching technique, I think, is really important. This is a Lee paper in the bottom right-hand corner that Dan Rue was a senior author on that talks about when you need to take that. And on that the X-ray didn't show up, but there's you think about those diminutive joints, that osseous erosion that occurs in C1-2 arthritis. That C1 lateral mass starts to kind of obliterate. And so at times you really do need to go through that arch, or maybe at least notch the bottom of it to get that screw into some good bone. And so thinking about when to use that really relies heavily on your preoperative evaluation, kind of that meticulous understanding of where that vertebral artery is and that intimate relationship with the posterior arch. One of the sentinel papers by Brad Currier, who kind of makes it every couple of years to this course, was really, again, something that somewhat of a historical component at this point, but something that has laid the foundation for how we put these screws in. And this is where he looked at CT scans with CTAs of where the internal carotid artery is anteriorly and whether or not you can place a bicortical screw. So again, some of the kind of CSRS founding members really putting forth really important information. So these are kind of my tips and tricks for placing C1 lateral masses. So again, identifying the start point. To me, it's very much the confluence as I follow the arch down. I'm packing it off, flow seal, pack it with a patty, move to the other side, and I just keep going back and forth until I find that arch and I can really get down onto that lateral mass. I spend a lot of time with the Penfield 4, feeling lateral, feeling medial, feeling lateral, and going back and forth until I really have a good understanding of this. And then once I'm able to do that, I usually have a good sense if I'm navigating or if I'm using fluoroscopy, am I just going straight along the arch? I almost use the arch as a parallel. As long as there's enough adequate stock there, bone stock in the lateral mass, I can almost follow that arch straight in as far as kind of heading into the anterior direction. The anterior arch kind of target that Dan Rue describes in one of his papers is that anterior tubercle. So if you guys look at that, kind of the end zones are the most cranial and caudal aspects, and that 30-yard line around the most caudal aspect of that area is really one of your tip of your screws. So I kind of aim for that area, both to stay out of the OC C1 joint, but also the C1-2 joint. And then you get all excited because you're there, you're like, oh my God, I'm really doing this case, it's amazing, and then you forget to decorticate the joint. So many times I'm like, all right, give me the screw, and I'm like, oh God, I didn't even get into the joint. Like, what an idiot. So take the time, get into the joint. The best way to do that really is to take your Freer or a Penfield, scrape down along the lateral mass until you pop in. And you usually have this big osteophytic ridge you got to get on top of, so you got to scrape down, and again, it's going to bleed like heck, and then you got to get the nerve right, and we'll talk about the nerve in a second, but you got to get up and over that thing, you got to get in the joint. I'll downsize my burr tip at this point. I don't use an A8. I use a smaller one so I can get into the joint. I can really decorticate the entire joint. Then you pack it with bone graft, BMP, whatever you're going to use at that time. Now, whether or not you take the nerve root, I think you hear some people are very dogmatic. They take it every time. Some people never take it. I usually try to preserve it as much as I can. Occasionally I have to, I don't take it, occasionally I have to take it. But I will tell you probably the most important thing of all that is you got to talk to the patient. Whether or not I'm taking it or not, I always tell the patient, hey, look, you might have some numbness. You might have some post-operative neuralgia in kind of occipital parietal region that you have to tell them about. So probably the most important conversation is to be had with the patient and not whether with yourself you're going to take it or not. So if it's in the way, it's not the end of the world if you have to take it. So I owe a lot of kind of my way I think about C2 fixation to Alpesh, and he really kind of taught me when I trained with him. And he's kind of like, thinking about this is kind of like the guy in the park who's offering you a bunch of drugs under his coat, like he has everything under the sun, what you need. And that's really what C2 is compared to C1, because you have so many fixation options. But a lot of that is really based on the way that you understand the anatomy. To me, this is the most beautiful aspect of anatomy, I think, in the entire human body, between what happens between the base of the skull and C2, because it's just amazing, not only from a bony perspective, but even like a neurologic perspective, and then most especially kind of from the vertebral artery. But understanding those subtle nuances, where the pedicle starts, where the lamina kind of, the juncture comes in, the pars, the SIP, the IAP, you got to know this stuff. And you can see up here in this right, I took this bone model and put some drill bits in it and took some pictures, and you'll see this throughout there. But take the time today to grab those models and look at them and really kind of drill that into your mind as far as what you're doing. I think I'd be remiss to not talk about probably the most important thing that's going to get you, and we're going to have a talk about this later. But really, the vertebral artery, you got to pay attention to this in this segment. And the anomalous vertebral artery can be relatively high, upwards of 5%. But the redundancy in the loop, I think it goes back to what I talked about before. there's so much rotation, flexion between the occiput and C2 that this vascular structure needs that redundancy to be able to kind of accommodate our movement. And so issues of anomalous vertebral arteries can be the most disastrous complication you can have, something you really, really want to avoid. So subtle things like the ponticulus posticus, you're bovine, you think you're on bone, and boom, you're in an artery all of a sudden. You got to pay attention to these things, and meticulous preoperative evaluation is really critical. This is a video I did for CSRS a couple years ago, and you can see as I took down the top of C1 arch, and this just kind of gives you an idea as far as that relationship where the vertebral artery starts to come in.
Here you can see us defining the posterior borders of C2, and also defining the left-sided pedicle screw tract into C2. You can also see the vertical component of C2 that's identified by the suture as it exits the transverse foramen. You can see that we flex the skull forward, identifying what remains of the left-sided posterior arch of C1. You can also see the course of the vertebral artery as it exits the transverse foramen and comes up vertically. You can see the intimate relationship between the lateral mass of C1 and just lateral to that, the vertical component of the vertebral artery. See us placing the high-speed bird. This is a good representation of how close you truly are to the vertebral artery. As if you were to stray out laterally, you could jeopardize the artery itself. We further define the relationship as it heads up over what was the posterior arch after laminectomy. See us also defining where it courses on the left above the posterior arch.
So we'll hear a lot more about that later in the next talks, but just again, you really got to understand this, and so this is no better time than while you're here in the lab to take the time to dissect that entire thing out. Know it now, because you don't want to find it in real life. So getting into the actual fixation of C2, so thinking about the start points, we kind of think about, okay, the technical aspects, you read it in the books, the confluence of the superior margin of lamina and kind of the pars, where it's coming. In reality, what I do is I just find the medial border of the pedicle. I take a pen field or a nerve hook, I find that, and as soon as I find that, boom, screws in, right? That's the highway into the actual body itself. So the trajectory is about 30 degrees medial, 30 degrees cranial, the way that I normally think about it. And to me, the preoperative evaluation, the axial CT, is really the critical piece of information that allows me to understand the bony corridor and kind of the osseous anatomy to see what kind of screw I can put in there. C2 pars, again, the start point for this, like I said, I always think about this like as a short transarticular, but about 3 to 4 millimeters cranial to the C2-3 joint, kind of the mid portion of the pars. And really, I think this helps to accommodate. So if you have a high riding vert, maybe that pedicle is not really an option for you. If I need to get this in, I can do that safely. I kind of aim it up a little bit more medial, a little bit more vertical, stay away from the vertebral artery, so it's definitely an option. And also very much an option outside of this discussion for kind of longer constructs, where maybe I'm doing like a C2 to C7 or C2 to T1, and I don't have to disassociate the muscular inserts that are onto C2. This is probably the most common screw when I'm kind of that I put in, and Rick hates when I talk about this. And this kind of came out of the Rothman guys with Kepler and Schroeder. But you can see on the far left, that's your standard pars. Far right is your traditional pedicle. And somewhere in between is what we call the parsicle. So I love this screw. I think it's a great screw, especially if you're using navigation. You can really zing some big screws in with this in the posterior cervical spine. But again, just something to be aware of, subtle variations in this as you think about it. This last screw we'll talk about is probably is something that I think is kind of an underrated screw. We have Neil Wright here, who essentially kind of wrote one of the technical, landmark technical articles about this. Rick loves this screw. I've become kind of an adopter of it. And I think really it offers so many options for you. You get so fixated on pedicles and pars and parsicles, whatever you want. But you don't need nav. You barely need it. You actually don't even fluoro for this. You can just get this in very, very quickly. And the bite on this is fantastic. It's a clicker the whole way through. So this is really a great screw. I think you guys should all try this. I didn't really see a lot in my training. I use it a lot more now in practice, and I think it's a wonderful thing. Kind of some of the subtle nuances are you sometimes have to marrying in the rod can be tough, so you might have to use an offset connector. I don't find it to always be an issue, but sometimes it can be. And the other thing too is looking at the sagittal cuts of your CT scan. You want to know if you can stack those screws and really make sure they're above each other. So it can get a little bit of a small real estate area trying to zing those across the lamina. So a couple quick case examples. So this is a 77-year-old lady, very classic kind of right occipital cervical pain. She's sitting in my office. She won't look. She won't turn. She kind of looks at me with a side eyeing me. Worse with head rotation. Here we routinely will do a C1-2 joint block. To kind of, from a diagnostic purpose, hers was floridly positive. So pretty classic C1-2 arthritis. You can see the erosions, both on the sagittal and the kind of the coronal images of that C1-2 joint unilateral on the unilateral side. And so I did a pretty classic construct here with C1 lateral mass screws, C2 translaminar screws. Again, in a 77-year-old lady, those C2 translams feel amazing when you put them in. So you get some really good purchase on bone quality that's not always the best. Just another one too. This is another kind of similar case. I bring this up just because it's a little bit of a mixed construct. She had kind of a aberrant bony anatomy, so you can see that C1 lateral mass is a little bit lower, just so we can accommodate for how eroded that lateral mass was. And then she didn't really have much of a pedicle for us to access, so we ended up putting a translaminar screw. So again, mixed construct here. You can do a lot in this region. A lot is at your disposal, so make sure you try it today. So thanks, guys. Appreciate your attention.